Welcome to the Reframing Eye Care podcast. Today's guest is Dr. Kaleb Abbott. Welcome to the podcast.
Thank you, Maria. Good to be here.
Yeah. For those of you that do not know Dr. Abbott, he is an optometrist and assistant professor at the University of Colorado School of Medicine. He is the faculty for both the Dry Eye Clinic and the Center for Ocular Inflammation, where he specializes in complex ocular surface disease and participates in clinical trials research pertaining to ocular surface disease. He serves on the board of directors for the Ocular Wellness and Nutrition Society, is the vice chair for Nutrition Disease Prevention and Wellness for AAO, and advisory council for Academic Medical Center Optometry, AAO, special interest groups, and recently has become the host of Dry Eye and Ocular Surface Disease section of the clinical podcast series for the American Academy of Optometry Foundation. So welcome.
Oh, so happy to be here. Yeah, thanks for having me.
Yeah, I mean, when I met you at AOA meeting, I was like, I need to have a dry eye specialist on the podcast to talk about what you do and maybe inspire other optometrists to do more dry eye, but maybe get involved in the hospital setting and research. So I'm so glad to have you on. If you can just give us, some description of your job and what you do.
Yeah, so like you said, I work at University of Colorado School of Medicine. I'm about 75% clinic and 25% research. And I practice in a dry eye center. So we're essentially a tertiary referral site. So we get all the difficult cases that nobody wants to see. So, I mean, we get severe ocular surface disease cases, graft versus host disease, a lot of Sjogren's syndrome. I've strangely become like a specialist in ocular cicatricial pemphigoid, and I now have a dual clinic where I manage the ocular surface disease components of that, and the patients also see a uveitis specialist who manages those patients systemically through immunotherapy. So, difficult cases like that, but a lot of neuropathic pain too. I mean, by the time patients get to our clinic, oftentimes they've seen 3, 4, 5 different eye care providers, optometrists, and ophthalmologists, and they kind of come to the university wanting answers and kind of as a last resort. So my job has kind of morphed into seeing a lot of very difficult eye pain cases and a lot of difficult ocular surface disease cases.
Yeah, so the patients that you're seeing are kind of like at the end stage of their dry eye, really looking for answers, and they're looking for like a specialist like yourself. How would they search for a doctor like yourself? And how do you see these patients, and what resources do you have for them?
Yeah, I think, when patients can't get the answers they want, oftentimes they want to go to a university or a hospital. There's assumptions that people that work in a hospital or a university setting, may have access to the latest and greatest things or more resources. And I think sometimes that's true, sometimes it's not true. But for better or for worse, they end up in our clinic, again, as kind of a last resort. And we're fortunate in that we can actually have a clinic that specializes in only that. So I don't really have to worry about doing a whole lot of annual eye exams. I don't do any glasses or contacts. I can pretty much just focus on dry eye. And as we all know, one big barrier to doing dry eye is the time commitment to it. These are patients that require a lot of education. A lot of times they're in a lot of discomfort and a little bit more high maintenance patients. So the counseling component takes a while. So being in a dedicated dry eye clinic gives me a lot of the time to see those patients. And then we have access to, a lot of tools and equipment to do a lot of diagnostic testing for dry eye and try to actually figure out the root cause of their dry eye and exactly kind of what's going on with their pain. And like I kind of alluded to earlier, and a lot of times these patients come in, they have dry eye symptoms, and then you take a look and they don't really have any signs of dry eye. And that's when I started to realize that dry eye is a lot more complex than I realized it was, because it's easy to tell dry eye in patients that have severe Sjogren's disease or thyroid eye disease or things like that. But some of the harder patients are the ones that the patients have tons of discomfort, and then you take a look and it looks like it shouldn't be perceiving pain at all.
Yeah. So you're seeing a lot of presentations that focus on corneal nerves. Is that like an interest to you? How did you get into that? And are you just because you're seeing more of those patients?
Yeah, I used to think dry eye was a lot was quite simple, and that, working in a dry eye clinic, I could see what was going on and diagnose it and prescribe things, trying to target, what was going on, if there's, inflammation or evaporative dry eye or aqueous deficiency and things like that. And then the more I started working in the dry eye clinic, the more I realized this doesn't seem to add up with not just some of my patients, a lot of my patients. I have patients that eyes look super severe that don't feel any symptoms, and then patients that feel all sorts of symptoms and they have no signs. Things just weren't really making sense. So I kind of went into a deep dive trying to understand what is going on here. And I think it was fascinating because the history of dry eye is so simple. It's just, Sjogren's syndrome. And this came out, people started thinking about it 70s and 80s maybe, and they thought, well, if you don't produce enough tears, the eyes become dry, and then you wet them with lubricating drops. And the problem is all these patients started showing up in, centers like mine and saying, my eyes are miserable, they feel terrible. And you take a look and they don't have Sjogren's and they don't have aqueous deficiency. Their meibomian glands seemed fine. And you realize that signs don't correlate with symptoms. And there's been study after study after study after study that proves that signs don't correlate with symptoms at all. So then, kind of in the quest for understanding what's going on with these patients, we started to get fancy. And we thought, well, let's look at tear osmolarity and matrix metalloproteinase 9 levels. And let's look at, for things like ocular rosacea and telangiectasia and lid margin disease and meibomian gland dysfunction, tear breakup time. Let's look at all these metrics. And we got all these metrics, we got real fancy, and still none of those correlate with symptoms at all. It's incredibly frustrating, but it also lets you know that we don't really understand dry eye as much as we think that we understand it, because we can't come up with a single test that correlates or predicts patient symptoms. So that's when I started to get very interested in corneal nerves. And I thought, we're really paying attention to just the ocular surface and just the corneal nerves that are right there. But when you think about the nervous system pathway, it's so long. You've got the trigeminal nerve nuclei, you have the ophthalmic branch of the trigeminal nerve, it goes to the nasociliary nerves, then to the long ciliary nerves, and finally to the corneal nerves. And the trigeminal nerve even courses down into, C1, C2 of the spine, and then before heading up to the midbrain and the medulla. So it's a very long path and long axon. So theoretically, if something's affecting anywhere along that path, it could be triggering symptoms for these patients. And I think the more I've started to look at corneal nerves and look at what research that's out there, the more I realize, well, we really don't understand this disease well at all. And a lot of the treatments that we're doing don't really make sense based off our patients' signs and our patients' symptoms. And we're treating all of this tangentially with all these drugs and kind of randomly throwing things at it. So I got very interested in corneal nerves and trying to, understand, how I can better serve my patients.
Yeah. So you have access to a corneal confocal microscopy. How has that changed the way you think of dry eye? I know you just gave us a great synopsis, but it makes me feel like I don't know anything now on dry eye in my practice. But give us a little bit on that in your setting.
Yeah, well, I realized one reason we don't think about nerves much is we don't really see them. When you're looking through a slit lamp, sometimes you'll catch a glimpse of a nerve there. They might have a prominent nerve or something like that. And that's really the only time you see it. And that's really the only time you think about it. But yeah, we have a corneal confocal microscope at the university, mostly for research purposes. But this will zoom 600x on those nerves. And you can see evidence in these patients that don't have any signs of dry eye but have excruciating symptoms. You can actually see evidence that there's something wrong. And we'll see that in the form of decreased nerve density. So there'll be kind of nerve pruning and there'll be much less nerves there than you would typically see. But the biggest thing that we find is correlated with ocular pain is microneuromas. So these are essentially nerves that have been severed. So they've been damaged, they've been severed. They form this kind of inflammatory ball, almost like of yarn. And then the nerve tries to regrow and sprouts off of that. And it's essentially the best that we've been able to correlate with patient symptoms. If you look at research, if for those that have access to a confocal microscope and they see microneuromas, that's very tied to ocular pain. So we'll see these microneuromas, we'll see nerve tortuosity, where the nerves are just, curved everywhere, nerve beating, and things like that. And I've had patients that have come into my chair before, and they'll be crying, they'll be upset, they'll be wearing multiple pairs of glasses. They'll say, everyone's told me I'm crazy, that my eyes aren't dry, that I shouldn't have any of this pain, but my eyes feel terrible. I can't function. I can't work anymore. I can't leave the house. And unfortunately, I see a lot of these patients. But then you do all the dry eye tests and you say that all looks normal, but then you do confocal microscopy and you see signs of a neuropathic pain. And you can be the first person to tell these patients that they're not crazy, that you can actually see a problem with their corneal nerves. And that's actually at the level of the subbasal nerve plexus. So this is like the anterior 1/3 of the stroma, that we can see evidence of pain even when it's not manifesting as dry eye.
Wow. So most of the people listening to the podcast are familiar with neurotrophic keratitis. Give us some information on that and elaborate on, the ocular pain and things like that for the listeners, and how they can incorporate it maybe into their practice if they don't have this microscope.
Yeah, I don't think you need to be able to zoom in 600x on the nerves for a non-billable procedure and a device that costs $80,000 to tell if something's wrong. Like there are other signs that we can tell. And when I think about dry eye, I don't think signs and symptoms. I think you'll drive yourself absolutely crazy if you think of it just in terms of that. You'll say, they have signs or they don't have signs. They have symptoms or they don't have symptoms. I think that's a bad way to think about it, because we know that nerves can be hypersensitive, like in neuropathic pain, or hyposensitive, like in neurotrophic keratitis. And so I really think about it, on a spectrum. And I think, where they are in terms of pain status and where they are in terms of ocular surface findings. And I always try to figure out, where is my patient coming in, with that, because they could be in any quadrant there. They could have signs and symptoms. They could have signs and no symptoms. They could have no signs but symptoms. So neurotrophic keratitis, that's obviously when the patient is having less symptoms than you would expect them to have, because those nerves aren't able to convey the pain and discomfort that that patient should be in. Yet they have a great deal of surface signs. So the cornea can be severely desiccated, yet the patients aren't feeling those symptoms. And neuropathic pain would be essentially the opposite of that, where the cornea in general looks fine, although there can be concomitant dry eye with it. But the cornea in general will look fine, but then the patient's symptoms are just way out of proportion with the signs. So, in general, whenever I'm seeing patients, I'm trying to elicit what their primary symptoms are, and I'm trying to tease out whether or not they're having any indicators that it could be neuropathic in nature. And it gets very complicated, because to understand this, I think you really have to understand different types of pain. So if we want to back up, so pain can originate from nociceptors. So those are pain receptors in the cornea. So that is pain that is from an actual or threatened damage to tissue. So if you think about a nail that's pressing on your skin, that's threatened damage, and so it's threatening, it's triggering mechanonociceptors of your skin, and then if it pierces the skin, and that's actual damage that's happened to your skin. But it should be transient in nature, and that's cases of like trauma, surgery, inflammation, things like that. And we have different nociceptors in our cornea. We have polymodal nociceptors that are detecting heat, that are detecting chemical stimuli, and then also physical touch to some extent. And then mechanonociceptors, that is literally only detecting pressure on the cornea. But then you also have cold thermoreceptors, which is kind of the most fascinating of all of them. It's detecting temperature changes in the cornea. When those tears begin to evaporate, it'll actually be able to detect that temperature shift and then fire. And then it's also detecting tear osmolarity as well. So that's a nociceptive pain. So that would be, that's what we think of with dry eye. So your eyes are dry, and you're taking a look, and you're actually seeing something like an ocular rosacea or a Sjogren's, or typical dry eye, evaporative dry eye, and things like that. And you say that makes sense because the dry eye is triggering activation of those nociceptors or those pain receptors. So that's the one that everyone thinks about. But then you can have peripheral neuropathic pain. And this is essentially a lesion or a disease of your somatosensory nervous system. So your nerves become hypersensitive. So the best example of this is probably like diabetic neuropathy. Like these patients end up getting extremely painful hands and feet. But those are of your peripheral nerves too. But your corneas are also peripheral nerves. So you can actually get eye pain in diabetics from their diabetic neuropathy. You can also think of post-herpetic neuralgia patients or LASIK patients that get severe eye pain after LASIK or even cataract surgery. And then the most confusing one is the central neuropathic pain. So this is essentially this is pain that's arising without evidence of nociceptive pain. So no dry eye or anything like that. No lesion or disease of the somatosensory nervous system, yet the patients are still experiencing pain. So this is really a dysfunction of the central nervous system or the pain processing centers of the brain. And cases of these patients will oftentimes also have like fibromyalgia, traumatic brain injury, small fiber neuropathies, or migraines, which is arguably a different type of neuropathic pain. So, when these patients are coming in, you have to kind of tease out, is this dry eye or is this neuropathic pain? Is this happening from nociceptors or is this happening from something further upstream in the nervous system? And some of the best ways to understand that is, there's certain terms that go along with neuropathic pain, like allodynia. So this is pain when there shouldn't be pain. So this is like patients that come in wearing all these pairs of sunglasses and they say, indoor lights absolutely kill my eyes. And that's, you shouldn't be feeling pain with just typical indoor lights, but these patients feel pain. So that's called allodynia. So you can have photoallodynia to lights. You can have tactile allodynia. So like I had a patient that came in a few weeks ago. I thought this was crazy. She said, if I lightly touch my upper eyelid right here, my eye will be in severe pain for the rest of the day. I thought, oh, that's tactile allodynia. Like that should not cause severe pain the rest of the day. Then these patients can also have hyperalgesia. So essentially something that should cause discomfort causes a lot of discomfort in these patients. So this is like something like wind. Like wind should bother everyone's eyes. But these patients will say wind kills my eyes. Like it feels terrible. So that's an example of hyperalgesia. These patients can also have prolonged pain, like that patient that I said that, she lightly touches here and she's in pain all day long. Or wind up. So they could go outside in the cold and their eyes are bothered, but then after an hour of being in really cold air, their eyes are absolutely killing them. That's called wind up pain. All these things are associated with neuropathic pain systemically, but also of the eyes as well. So you can be kind of asking questions like that, seeing if they have any symptoms that line up with that. Other things that can clue you into neuropathic pains is, again, more symptoms than signs. They could have a lack of response to traditional dry eye therapies. But some of the biggest risk factors are really like other chronic pains, like chronic pain syndromes, fibromyalgia, chronic fatigue, migraine, small fiber neuropathy, irritable bowel syndrome, trigeminal neuralgia, things like that. So these are a lot of the cases that end up coming into our clinic. And actually, it's funny, I get so many referrals from neurology now that they don't refer to it as Dr. Abbott's dry eye clinic. They call it Dr. Abbott's pain clinic or eye pain clinic.
Yeah.
So for better or for worse, I end up seeing a lot of these patients. They're difficult cases, but very rewarding when you can help them.
Of course, yeah, it's very. So for the average optometrist that's seeing this in their clinic, how do we treat it? How do we help these patients if we don't have Dr. Abbott next door to us?
Well, I think first you have to really try to understand, is it peripheral neuropathic pain or is it central neuropathic pain? Because you'll waste a lot of your time trying to treat an eye that is in discomfort if it's a problem originating, in the pain processing centers of the brain, those central nervous systems. So one simple test that you can do in office is just the Prepare-A-Cane challenge. So you essentially ask the patients, to think about how much pain they're in, kind of at baseline right then, how much light sensitivity they have, the amount of burning they're having, pain like that. Then you say, I'm going to put a drop in your eye and reassess 60 to 90 seconds later. So you put a drop of proparacaine in, then you wait 60, 90 seconds and you evaluate them. You ask them, what is your pain now? And if they tell you, my pain has remained unchanged, I'm still super light sensitive, my eyes still burn, they still hurt, then you know that doesn't make any sense because you just numbed the corneal nerves. They shouldn't be feeling that pain. So then you know that it's either central neuropathic pain or non-ocular. So in those cases, it's very tricky. Now, I kind of push, I push the envelope and practice a little more aggressively. So I do a lot of Lyrica and gabapentin. I work with pain specialists that do nerve blocks of the trigeminal nerve and things like that. But you'll waste your time doing eye drops and typical dry eye therapies in patients like that. IPL may work though, because it can target, further upstream along the trigeminal nerve. But then if you put in the proparacaine drop and they say, my eyes feel a lot better, and they may say like 70% better, 80% better, then you know that 70 to 80% of the pain that they're feeling is either peripheral neuropathic pain or nociceptive, or dry eye. You have to, as the clinician and doctor, figure out, is it dry eye or peripheral neuropathic? But then you know that topical treatments will work. And if you really think that it's a neuropathic pain, then focusing on things to try to help those nerves out is the best thing that you can do. So autologous serum eye drops, platelet-rich plasma eye drops, things like that. But you have to kind of keep in mind that the rule of thumb is always treat nociceptive pain prior to neuropathic pain. So you have to treat any dry eye that's there first, then worry about the neuropathic pain. So I do a lot of autologous serum mixed with steroids, or autologous serum mixed with a topical immunomodulator. There's evidence that you can remodel that subbasal nerve plexus, or those corneal nerves, in as little as 4 to 6 months with the combination of autologous serum eye drops and a topical immunomodulator. I'll do IPL scleral lenses just to reduce input to those nociceptors. FL41 tinted glasses if there's light sensitivity, some supplements like alpha lipoic acid, things like that. But yeah, for the average person, you need to try to figure out, are their symptoms out of proportion with their signs? See if they have any allodynia, so pain when there shouldn't be pain, hyperalgesia, so way more pain in response to something that should only cause a little bit of pain, like wind. Is there prolonged pain? Does the pain radiate along the trigeminal nerve or the eyelids? Try to figure out if it's neuropathic, and then use the proparacaine test to try to figure out where is it. Is it of the corneal nerves or further upstream? I've wasted a lot of my time and energy trying to treat central neuropathic pain with topical eye drops before I kind of realized some of these tips and tricks.
Yeah, I appreciate you coming on the podcast and giving us all this information. I feel like I don't know anything now on dry eye and this, but I've learned so much from you, and it's great to have this information, because I do have 1 or 2 patients that I've seen in my practice, say they have pain, and you look just traditionally with the slit lamp and there's nothing there. So I hope other listeners get the same information and, be able to help patients or even identify and send them to the right resource. So thank you so much for coming on and being such a great resource for information. It was a very insightful. I actually learned a lot, actually. So
I'm happy to talk about it. This is something I'm quite passionate about. I always tell patients, most of these patients that have neuropathic pain, they have pain elsewhere too. And I always tell them pain travels together. So very rarely do they just have eye pain. They'll have, neck pain, they'll have head pain, they'll have migraines, this and that. And I always tell them pain travels together. And I think there's a lot of arguments to be made now that a lot of our dry eye patients are really, they have symptoms that are actually just a manifestation of a systemic problem that they have, like a chronic pain throughout their body manifesting as dry eye. So something for people to think about.
Great. Thank you so much for coming on the podcast. I appreciate it.
Of course. Have a good day.